Hi, everyone. Do you want to put something on the chat function just to make sure that it is all working okay? Yeah, it's working all okay. We'll wait for a few minutes before we start. I need to sort out accept all, of course. Okay, yeah, it's working all okay. We'll wait for. Perfect. So we are live on YouTube. We'll wait for a couple of minutes for people to join. It's still only 4 o'clock now. A couple of hundred people online. Perfect. And attendance. I assume that Andreas is not feeling great. He's not with us. So let's see. 6. Nasos, I'll text you now just to make sure it's all working okay. Is that okay before we start?
Yeah, of course. Please do that.
Sometime. I'll try in a couple of minutes, I think. Computer says no. Good evening, everyone. It's great to see you all again. We have 200, nearly 300 people online. We'll wait for a couple of minutes. There's about 1,200 registered, so we're expecting closer to 400 people joining at least today. It's different webinar. We usually talk about cancer and we used to talk about surgery, but this time we are talking about benign breast conditions. Nearly 90% of what we see in clinics are all benign, and it's the least thing, or more than 90%, and it's the thing that we least look at. Uh, so we have 4 fantastic talks, one by Leff on breast infection, one by Fatayer on breast pain, then one by Barbosa on nipple discharge, and one on skin conditions of the breast by Jenny Hughes. Ricardo is not with us today, so there'll be no Spanish channel, but we have Akram and he'll be doing Arabic channel, and we have Katya who's going to be doing the Russian channel, and we have Nasos Zouzos is one of the radiologists from Sweden, is going to be on the panel. Not sure if Andreas is able to join or not. If he feels better, he might join halfway through the webinar, but he was not feeling great earlier today. So hopefully have a speedy recovery. Now, as usual, if you have any questions, please put them on the Q&A section. Don't put them on the chat. If you want to put anything on the chat, you can see there's lots of messages on the chat function. It's great to see all of you from the different parts of the world. And without any further delays, we'll just start with the talks. And we'll start with Dan. And Dan is going to talk about breast infections, 15 minutes, and then we will do the discussion after that. Because there are 4 different talks, we'll do talk and this followed by discussion. Dan, the next 15 minutes are all yours.
Fantastic. Thanks very much. I'm hoping you can see my screen.
Oh, it looks fine.
Yeah. One sec. Sorry.
Perfect. Yeah.
Take it to the beginning. Sorry.
Beginning is better. Yeah.
Yeah. Of course. Yeah. So afternoon or evening, everyone, wherever you're broadcasting from in the world. Yeah, it's a really great pleasure to join this webinar. Yazan, thanks very much for the kind invite, and it's really great timing actually for us at Imperial with the MAMA-VAD trial about to go live. So I've got no relevant financial disclosures or conflicts of interest. So many of you on the line will know that mastitis and abscess is a really common condition affecting between 5 to 33% of women. The Getting It Right First Time audit told us that it affects 2.5% of admissions, approximately 1.2% of surgery. And that translates to about 2,000 avoidable potentially admissions and 1,700 procedures, actually is quite a substantial proportion of procedures that are potentially avoidable. We know from our own local data, as I'll show you, there was a lack of uniformity in antibiotic prescribing and a 40% inappropriate, actually, first-line antibiotic prescribing. Quite wide range in the literature of incision drainage procedures being performed, and we know that incision drainage is associated with poor quality of life. And pretty outdated guidelines, actually, on both antibiotic prescribing and management of breast abscess. So the first step that we took in this process was to audit our own local practice. So we essentially audited our practice at Imperial of the management of mastitis and breast abscess. And then we conducted a quality improvement project where we essentially put a new pathway in place. And then we re-audited phase, as you'll see in the graph there, phase 2 and phase 3 are the after pathway introduction, A, to see whether there'd been any change in practice, and then B, to see whether that change in practice had been maintained. And this slide summarizes for you the results of that process. So we saw an increase in first-line antibiotic use, a significant increase in the use of ultrasound, pleasingly increase in specialist follow-up, because of course there's concern about potentially missing cancerous mastitis. You will see on the chart on the right of the screen, the orange bars represent the proportion of specialist follow-up, and you'll see in phase 1 that was pretty low. By phase 2 and by phase 3, there was near complete follow-up with specialist breast physicians or breast surgeons. We saw a significant reduction in the rates of incision drainage, and we saw reduced hospital admission rates, although this was not statistically significant. We then set about seeing what was happening nationally through this MAMA audit. This is Mastitis and Mammary Abscess Management Audit, and this was a multi-phase prospective UK audit. Phase 1, we asked questions about the care pathways that were in place on the ground, and in phase 2, we actually assessed the management of patients with real-time data capture. In terms of inclusion criteria, patients over the age of 16 with mastitis or breast abscess, and the exclusion criteria were a concomitant diagnosis of breast cancer, breast surgery within 90 days of presentation, and or a breast implant on the affected side to exclude those infections related to implants. So you'll see this is a snapshot of the number of hospitals that we had participating in phase 1 and phase 2 of this multi-phase audit. You'll see that approximately 80% or so of units were involved in the second phase of the proportion that told us what they said was happening on the ground. We had 80% provide us with real-time data. What did we measure? Hopefully a lot of this would be obvious to you, but we've measured socio-demographic variables, the mode of referral. So is that from the general practitioner or family doctor, or from emergency care? Whether or not the breast team were involved in the care of the patient, whether the patient was managed as an outpatient or whether they were admitted, what lactation advice was given, if it was appropriate, if it was a lactational mastitis or lactational abscess, the choice, route and duration of antibiotic therapy. We asked for questions regarding any microbiological analysis that was done, and the access and use of ultrasound aspiration and justification for incision drainage, if incision drainage was indeed performed. This shows you the breakdown of the hospitals, 69 hospitals in total in phase 2, 55 in England, 3 Scotland, 3 in Wales, 2 in Northern Ireland, 6 in Ireland. That led to data capture on 1,350 patients, and only 38 records had to be excluded. This shows you a summary of the results of MAMA. This is the care provider involved according to the day or time of presentation. You can see that's broken down to day of presentation on the left of the screen, time of presentation on the right of the screen as you look at it. The breast team involvement is color-coded blue, so you should be able to see there that Monday to Friday, and at least during the day, breast teams were involved in the care of the patient, but just under 50% of the time. I guess with shifting subspecialization and changes to our on-call or take, where more general surgery covers breast conditions over the weekend, I guess it's not surprising to see the reduction in the relative proportion of breast team involvement at the evening and weekends. This slide shows you the source of referral by date and time of presentation. Again, day of presentation on the left of the screen, time of presentation on the right of the screen, color-coded by general practitioners, GP, emergency departments, ED, maternity and self-referral. You will see that general practitioners were the predominant source of referral Monday to Friday during normal working hours, whereas at the weekend, I guess unsurprisingly again, the bulk of the referrals were from the emergency departments, and a small proportion from maternity and a very small proportion of self-referral. This shows you a summary of the admission versus outpatient management and who is deciding the admission of the patient in terms of the grade of the doctor making the decision for admission. You'll see that 77.5% of the patients were managed as an outpatient basis and only 22.5% were admitted. But I still think that represents an opportunity to perhaps reduce the admission rate further when we consider that 22.5% of patients with mastitis are being admitted to hospital. When you look at the grade of the referrer, you'll see that the decision to admit is predominantly being taken by the specialist registrar grade, although the consultant is involved in that decision, a fair proportion of the time, particularly Monday to Thursday and during daytime hours. This slide shows you a breakdown of the proportion of patients that were treated as an outpatient or admitted Monday to Thursday, Friday, and then at the weekend. You should be able to see from that graph the proportion of patients admitted, i.e. the red bars, are that much greater on the weekend than during the working week. And in fact, we found that the odds of being admitted were significantly higher at the weekend compared to the weekday. Perhaps that's not so surprising to many of you, particularly in the UK practice. In terms of antibiotic choice and duration, first-line antibiotic was coamoxiclav in 42.7%, second-line metronidazole in 36%. You'll see that 7 to 10-day course of antibiotics was the greatest proportion at 46%. It was interesting to see that approximately 35% of patients were being prescribed antibiotic courses that were less than 7 days. This table shows you a breakdown of the proportions of patients receiving ultrasound-guided aspiration versus incision drainage, and that's broken down by type of abscess, as you'll see on the left. 81% of lactational abscess receiving aspiration, 60% or so periductal abscess receiving aspiration, but still quite a high proportion of patients receiving incision drainage, both for periductal and for lactational. I think interestingly, needle aspiration we found was access to needle aspiration and an attempted needle aspiration significantly reduced the chance of a surgical incision drainage procedure. I think this is probably the headline slide from the MAMA audit, actually, because this shows you the rate of incision drainage as a funnel plot for each unit, where each red data point in there is a unit, and it's organized by the number of abscesses that the unit's treating. I think it does show a volume outcome relationship with centres that are seeing greater numbers of abscesses, seemingly performing less incision drainage procedures. But it was a surprise to us to see that green line of the average rate of incision drainage was higher than we would have expected at about 20%. When we asked for justification for incision drainage procedures, this is the proportion these are the indications that we received back and their relative proportions in brackets. You'll see that pointing, size over 5 centimeters, multiloculated, duration, and other unspecified were the justifications that we received for incision drainage. And arguably, one may say, well, other than skin necrosis, perhaps these other indications should have at least have an attempted ultrasound-guided aspiration. When we looked at the predictors of incision drainage, the strongest were severe sepsis and rapidly progressing infection with skin necrosis. So I guess the summary of the MAMA project so far is essentially high rates of incision drainage with a greater likelihood of admission and incision drainage over the weekend, and quite wide variation in the use of incision drainage across the country. We believe that efforts should be made to reduce the incision drainage rate where possible, because we know that that is associated with pain, prolonged wound healing, and scarring compared to radiologically guided drainage. A relatively small proportion of patients, to our mind, did get an attempt at aspiration prior to incision drainage. Only 40% of patients reviewed by breast specialist teams in the UK at index presentation, and very few departments seem to have rapid access to breast clinics during working hours. So perhaps there's some work to do there. The next steps are clearly the development of a national toolbox for breast practice, and myself and others on the Clinical Practice Standards Committee are currently trying to address that as we speak. The pathway is likely to look something similar to the local pathway, and this shows you the local pathway that we put in place at Imperial, which essentially divides the patients up into those that are clinically well, those that are clinically unwell, aid memoir for decisions to admit, decisions regarding antibiotic first-line and second-line therapy. Just switching gears slightly in the last literally minute or two to tell you about alternatives to incision drainage. One that we're exploring at the moment is vacuum-assisted drainage, which for many of you that are used to vacuum-assisted excision is a similar procedure in that it's performed under local anaesthetic. A small incision is made, a vacuum device is inserted, and under ultrasound guidance, the abscess is essentially aspirated, preferably to dryness. Is there any experience in the UK of vacuum-assisted treatment of lactational abscess? Well, Simon Cawthorne's team about 20 years ago published this paper, the experience of 5 women, all of whom had resolution at a much lower cost than the cost for surgical admission and incision drainage, although quite a high number of clinic appointments, and 2 patients required repeated vacuum-assisted drainage. Why try this, I guess, in a trial? Well, the high rates of incision drainage really motivated us on this. I mean, the incision size for the vacuum versus a surgical incision, clearly you don't need a randomized trial to see the difference in the size of the incision. But patients are, in the literature, are more dissatisfied with surgical treatment of breast abscess versus radiological treatment of breast abscess. That's published. Our own patient focus group told us that patients that have had surgery versus incision versus radiological aspiration, those that had surgery said they were left terribly scarred and or deformed. We conducted a survey through our social media channels, which told us that those that had surgery, 90% of them said that their breast was left considerably scarred. 70% of them said they were left with deformed breasts. The sum total of VAD in the literature is about 400 patients. There are no RCTs yet. It has some advantages. There are few treatment failures. It can be delivered on an outpatient basis with potentially lower post-procedural pain scores than surgery, and with excellent cosmetic outcomes. There is experience of vacuum, of course, in the internationally and in the UK through the breast screening program, and there's collegiate support to investigate vacuum-assisted drainage, with 26 sites expressing an interest in participating in the MAMA VAD trial. So this just shows you, this is the last few slides, it shows you the breakdown of the schema of the MAMA VAD trial. Those women that have a abscess that's large, defined as more than 5 centimeters, and multiloculated, where the abscess has failed a standard needle aspiration, where surgery would be the next step. We are asking units to randomize those patients to standard of care surgery versus vacuum-assisted drainage. And you can see there we're collecting quality of life scores, breast-related quality of life scores. We will evaluate time to resolution, antibiotic use, duration of discontinuing lactation, length of hospital stay, and failure of the technique. Obviously, it's me presenting today, but there's been a huge effort behind the scenes with a large number of people involved in both the MAMA and the MAMA VAD trial, which I'm grateful for all of those that are named on the line. So acknowledging all of them. Thank you very much. I hope I'm probably out of time, so thank you very much for your time.
It's a great talk. Thank you for that, Dan, and it's up to the point. I think the key things, remember, we have more than 500 people online now.
Yes.
So, and people will come from usually more than 100 countries. In some parts of the world, the treatment for abscesses is always incision and drainage. And the key message here is that in the majority of patients, you do not need to do that. So if we get also If Hiba and Karen also are also online, if they can join for the discussion, that would be great. Now, start with simple questions, simple answers, Dan. So first line antibiotics. What's your recommendation from all the
Well, so our internal review, and in discussing this with microbiologists, it was co-amoxiclav really. There was as long as the patient's not allergic, of course, would be the first line. So that's what we use in our center. That's in our pathway. Yeah.
And there's a question online. People are asking about lactational abscesses and breastfeeding.
Yes.
And the key thing is just keep on breastfeeding. Don't worry.
Well, I mean, I think it's really interesting because both my clinical experience and when you read online, you read all sorts of things. But yes, there is no reason that the patient has to stop breastfeeding, actually. So you can continue to breastfeed, certainly with mastitis. With lactational abscess, if we're going to perform an incision drainage, we often suppress lactation, right?
Yeah.
Well, that's quite common in a lot of centers. But we one of the outcomes of MAMA-VAD that we're really interested in is what is actually happening on the ground. How are women stopping breastfeeding? How long are they able to breastfeed for with vacuum versus surgery and so on?
And the reason to stop breastfeeding when they're doing incision drainage is to mainly avoid a fistula, isn't it?
Basically, yes. Yeah.
And let's take. So Hiba also works in the UK, so the practice is very similar. Am I correct in saying that we're working up north, Hiba?
Yeah, I mean, we tend to, as Dan said, give co-amoxiclav for non-lactational. For lactational women, our first line is Fluclox.
Yeah.
But if it doesn't work, co-amox is our second line. So it's pretty much similar.
Yeah.
Also very similar where I work. In Scotland, we were mainly Fluclox based on a local audit and augmentin only if this fails, and then according to culture. Karen, in the States, anything different? You're on mute, Karen.
Yeah, sorry, I just want to make sure my mute was off. No, I think it's pretty much the same thing. I always try to, when I'm doing the ultrasound guided aspirations, I will use the local, and I always give the analogy of adding milk to the milkshake. So if you've got something very viscous, a lot of times people are going to sit there and advocate towards an incision and drainage because they're saying it's very organized or it's very thick and they don't think it's going to drain. I use the local to break up some of that, and I do a couple of passes to break up loculation. So I think you can get a lot further with those two little tips.
I think, yeah, sorry, I'm just yeah, that's exactly, Karen, where we're thinking vacuum could be really helpful here, right? So, so many times it comes back, oh, it's too thick to aspirate, right?
Yes,
so
yes.
Don't incise, vacuum that thick, organized collection out.
Well, I think it'll be interesting to do your study and find out, because if they're having access issues to just an ultrasound and needle aspiration, how is it going to be even more limited potentially to try to go vacuum assisted? I know in the US, a lot of breast programs don't have even an ultrasound in the office, let alone the access to vacuum assisted unless they're sending them to radiology.
But I think the key thing is that if even you don't have vacuum, at least try to, with a large bore needle, a bit of local, and I always wash out, flush with local.
Yeah.
When we go back to Dan, Nassos, from the radiology point of view, any tips and tricks on how you do the aspirations? Is there anything that you do differently if it's thick, if it's multi-faceted?
Yeah, well, it depends how thick you think it is in ultrasound, the material inside. Probably if it's not so thick, you can try with a fine needle, but most of the times it's really thick. So we could use a thicker needle. I mean, we can go down to a 14G, maybe like the same as core, but it's an aspiration needle. And if it doesn't work, then the VAD is also a really nice option. I mean, we don't have to go to a vacuum assisted excision needle size. We can go to a 12G. Now there's so much different sizes in handheld vacuum assisted needles. So you can go to a 12G needle, and I think it will work just really great to aspirate the abscess. We don't use as much drain as most of the cases. I think we prefer to take out all the material that's inside and try with antibiotics. If it's needed, then we can come back and aspirate a little bit more some other day. Yeah, VAD. The problem with VAD is probably the pain the patient has. So a lot of local anesthesia should be fine. Otherwise, all the things Daniel said it's really, really nice.
Dan, you have your hand up?
Yeah, and I was just going to say, I've just recognised, I'm just going to lower my hand. I also recognise that there's an international audience here, and maybe there are, you don't have access to even ultrasound, in certain parts, even in certain parts of, UK, you can't get access to urgent ultrasound to aspirate. I was taught actually when I was coming through, if it's an obvious clinical abscess, get a needle and then just aspirate it yourself, right? I mean, I know that's not as you may not be able to aspirate it to dryness in quite the same way as if you had ultrasound available, but it doesn't mean you couldn't apply aspiration rather than resorting to incision, right?
And remember, many of the surgeons in other parts of the world, and for example, in Egypt and Turkey and many other parts of the world, I know that they have their ultrasound scan machine in their clinic, and they can do the ultrasound scan and aspiration themselves. They don't do diagnostic radiology, but they can do things like that aspiration, which is guided. Hiba and then Karen. Hiba?
Thank you, Yazan. I think it's really important also to acknowledge that these women need to be seen quickly. In my unit, we tend to bypass A&E. So if patients come to A&E, they ring us directly. And if we've got capacity, we see them on the day. Or if they're well enough to wait for the following day, so we fit them into our clinics. We do have direct access to ultrasound through radiology, but as you said, if it's thick pus and they can't drain it, then a stab incision in clinic and a washout using local to help liquefy the pus as much as possible. And seeing patients regularly on a weekly basis is really important to avoid them getting to the point where they might need surgery and where we look at vacuum assisted aspiration.
And Karen?
Yeah, I also make sure that I tell patients that now that we have a venue for the abscess to drain, that they should use warm, moist compresses to help kind of bring out the rest of it, break up any loculations by massaging it. And I do the same thing. I bring them back because, gosh, you don't want to miss something that's underlying and assume it was just an abscess when there could be something smoldering underneath. So I always bring them back.
There's a couple of questions online. I just want to answer them. So some people are asking, what's vacuum assisted versus simple needle? Vacuum assisted is a larger needle that's connected to a vacuum machine that puts negative pressure. It's what they do, the radiologists do for larger volume. It's a bigger needle, so that will help break things from inside and get most of the thick pus out. It's not available everywhere, but if it's available, it's a good option. Lactational abscess, there's lots of questions about lactational abscess and milk duct fistula. I haven't seen a fistula forming after a needle aspiration from a lactational abscess. I would not suppress lactation if we can aspirate it, but some people argue that if you're going to take them to theater, that's when they give the cabergoline. Dan, any comment on that?
Yeah, they're pretty much exactly as you said, word for word, Yazan. I mean, we don't suppress lactation if we're going to aspirate. In the MAMA-VAD trial, for anyone who's interested in participating, we're going to monitor rather than protocolize suppression of lactation. We have a lactation specialist as one of the co-investigators who's really keen to see what the outcomes here are in terms of how long women can continue to breastfeed for and the variation in advice, I guess.
And is that trial open only for the UK, or are you happy with international collaborators?
Unfortunately, because then I'd be very interested to talk to anyone who wants to talk about this. So please do email me separately. But I think the challenge we have is that the NHR funding will only fund a certain number of units in the UK, sadly. So, but it would be great to be talking about this internationally if anyone's interested. Yeah.
So if anybody interested, most of you have my number, and I'll also share the WhatsApp channel. You can find my number on the WhatsApp and just text me, and we can sort things out, and I can connect you with Dan, and he'll be able to answer that. There's lots of questions about IgM and granulomatosis mastitis. We had a couple of talks about it in the past. You'll find it on the YouTube channel on the previous webinars. I think IgM will need a full webinar if we get to address it. We cannot address it in 15 minutes time because we really don't know that much about IgM. Now, questions about if it's antibiotics are not working. If it's a combination of antibiotics and aspiration are not working, you just need to think again about switching antibiotic. You'll have a culture about that stage, and you need to think about doing something more. And there's lots of other questions on the online. I'm sure Dan will have a quick look at them before we close this part of the webinar. Now, the last thing is drainage in periductal mastitis. Fistula is a big problem in that cohort of patients. Do you do anything differently for that cohort of patients or not? Because most of it will be pointing at the edge of the nipple areolar complex, and that's where the fistula happens. Will you drain it from elsewhere, or will you just go through the weakest point? Any thoughts about that?
I mean, we in our unit anyway, we really try to avoid incision, right? So we really aim to, and a lot of those can be aspirated successfully. I agree. I think part of the challenge is actually not attacking the source of the problem, i.e., not managing the fistula well. I've lost count of the number of patients I've seen that have got a clear fistula where it's been treated with antibiotic therapy and no one's thought to actually address the fistula. If you don't address the fistula, that patient will be back again in your clinic or in another clinic with another abscess. So attacking the fistula is, to my mind, key. But that's a good indication for surgery, in my view.
And also attacking the smoking, which is the most common cause for this, isn't it? Now, many thanks. It's great talk, Dan. Now we'll go to Hiba's talk about breast pain. And do you mind, Dan? There's quite lots of questions on the Q&A.
I'll have a look. Yeah, many thanks.
Many of them we've answered, but some we haven't. So have a look at that.
Thanks for the opportunity again. All the best.
Perfect. Thank you, Dan. Now we have Hiba Fatayer, and Hiba is going to talk to us about breast pain and massagia. And in all honesty, I have no clue what to do with breast pain in many occasions. So Hiba, we're going to help me to manage my patients from now on. Hiba, the next 15 minutes are all yours.
Thank you, Yazan. Thanks for this opportunity to talk on this amazing platform. So as you said, breast pain is very common. It can affect up to 77% of women at some point in their lifetime. The two most common concerns that patients come to our clinics with when they come with breast pain is one, the fear that their breast pain is a symptom of breast cancer, and then the second, that it can have impact on their quality of life, especially if their breast pain is severe. As clinicians, we think of it as a trivial symptom, but for a lot of women, breast pain causes significant concern and discomfort as well, and anxiety. So I've got no conflict of interest to declare. Just briefly talking through presentations, patient can present with different types of breast pain. It could be sharp stabbing, burning, heaviness, dull ache, involving usually bilaterally and not localized, although we do get women with localized breast pain. It can be intermittent or constant, and it can affect both men and women. And we know causes for breast pain can be many in younger patients in their 30s and 40s. They more commonly present with cyclical breast pain, where they start with pain as early as mid-cycle due to the surge in estrogen and progesterone, and the pain progresses and usually subsides as their period starts. In non-cyclical breast pain, there are different multiple causes, such as different benign breast conditions that can result in breast pain, musculoskeletal pain from the chest wall, the pectoralis muscle, the costochondral joint, radiating pain from the shoulder, neck pain. There are different presentations that patients can come with, thinking that it's coming from the breast itself. Patients on contraceptive medications and hormonal replacement therapy are also, they do present with breast pain. The certain antidepressants such as fluoxetine and sertraline can result in breast pain, as they can raise the prolactin levels in our bloods, which can affect the breast tissue. There are other different causes: stretch Cooper's ligaments, trauma, surgery, infection. In my experience, by far the commonest cause of non-cyclical breast pain is women wearing a poorly fitted bra. And I don't know if you ask patients on a regular basis, but I certainly do. And most of them do not get formally fitted for a bra, which is one big risk factor. There's limited and low-level evidence on diet and lifestyle factors, but it's believed that caffeine, alcohol, dietary fat, and stress can also result in breast pain. How to assess these women? I think it's really important to take a detailed history from them to try and establish whether it's a cyclical or non-cyclical breast pain, and try to tick all the questions on the different causes of non-cyclical breast pain. I usually try to find or use this opportunity as a solving a puzzle, trying to find out what is the cause of my patient's breast pain to make it more interesting. Full examination is really important, and whether imaging is required or not, it depends on the clinical examination. Now, is breast pain a cause or a symptom of breast cancer? I think it's really important to look at the evidence we have to date on that. This is a systematic review by Martin Diaz et al., and they looked at 7 relevant observational studies with some methodological limitations and very low quality evidence. Their review showed that there's low breast cancer prevalence overall, ranging from 1 to 2%, with low rates of incidental breast cancer diagnosed in non-painful areas in patients with normal examination at 2 to 2.3%. They concluded that there's very little research to inform about the effects of performing or avoiding imaging, and provided weak recommendation that primary care can be a good location for managing women with breast pain, provided that these clinicians have access to a well-defined protocol and also easy access to secondary care where clinical advice and imaging is provided. This is a more recent and large prospective cohort study conducted by our Manchester colleagues at Wythenshawe Hospital. They studied over 10,800 patients who were referred to their breast pain cancer diagnostic clinic over a period of 12 months. Out of those, 18% were referred with breast pain only. And out of those women, 56% had a mammogram, which was normal or benign in the majority of cases. The incidence of breast cancer in this cohort of patients was 0.4%, which when compared to patients presenting with other symptoms, it's much less significant. 38% of those patients were diagnosed with breast cancer in the contralateral asymptomatic breast. They demonstrated that normal breast examination had a 99% positive predictive value in predicting a normal mammogram, and concluded that in the absence of other breast symptoms, there's no association between breast pain and breast cancer. The Association of Breast Surgeons in the UK released a statement in February last year, highlighting that there are many women referred to our breast diagnostic cancer clinics, up to 41% with breast pain only. And these could be better served outside the one-stop clinic and avoid the inevitable anxiety of referral to the breast cancer clinic. When comparing the incidence of breast cancer in women with breast pain only, as published by the Manchester Group, it is approximately half the detection rate we pick up in asymptomatic women through the National Breast Screening Programme. So the percentage is really, really small. And NHS England released a statement to primary care during COVID, flagging that patients who do not have any red flag symptoms should not be automatically referred to urgent cancer pathways. So our Association of Breast Surgeons would not recommend routine use of ultrasound scan in patients with breast pain in the absence of focal, palpable or mammographic finding. Looking at the Breast Society of Breast Radiology guidance, which was released in February 2023. They do not advocate for any imaging for patients with breast pain only. They would advise, if there's any clinical concerns, that these patients should be referred to the 2-week wait breast cancer clinic pathway. The American College of Radiology finds it appropriate to image women with persistent focal and non-cyclical breast pain or tenderness with both mammogram and ultrasound in women over 40 and ultrasound only in women under 40. Now, how should we manage patients with breast pain? I think in my practice, most patients, once reassured and I spent time with them talking through the causes of their breast pain and what things to look out for and things to consider, they are happy and they're relieved that they don't have breast cancer, and majority of them don't come back. It is found to be effective in more than 70%, and women are advised to keep a prospective breast pain diary to try and establish whether their pain is cyclical or non-cyclical. This study from the 1999 looked at the value of clinician reassurance without imaging for women with breast pain only, and they sent these women questionnaires 2 to 3 months after they were seen in the clinic, and compared pain parameters in patients before and after treatment. And as you can see, the success rates were quite high, up to 70% in all women with reassurance. And patients that mostly benefited from reassurance were those with mild to moderate breast pain, although we still see quite significant improvement in women with severe breast pain. Lifestyle changes such as reducing caffeine, dietary intake, alcohol intake, and trying to have regular relaxation methods can help in reducing breast pain. Again, it's very limited and low level evidence to support this, but usually it's helpful for women in general for their, changing in their lifestyle. Bra fitting is another key factor that I stress on in my clinics and talk to patients about. There's a huge misconception amongst women about bra fitting and sizing, and many women lack basic bra knowledge. I think it's really important. I don't know how many people ask women to put on their bra in clinic and assess them. Things that I highlight to women when they go find a new bra or get measured formally for a bra, what to look out for is the back strap of the bra. It has to be sitting flat on the back of the chest and not pointing upwards. Women should be able to pass 2 fingers between the back strap and the back. The underneath of the bra should be sitting flatly on the chest wall, and the wires of the cup should not be digging into the breast tissue laterally or medially. And the triangular area that separates the 2 cups of the breast should be sitting flatly on the chest wall to help separate the breast glands. Also, the cup of the actual cup of the bra should be sitting flatly on the chest and not digging into the breast, causing an overspillage or having a gap, which would not provide enough support for the breast. We would advise women to wear a soft supportive bra at night if their sleep is affected. There are different medical treatments that have been looked at. Topical steroids applied 3 times daily for 6 months was found to be superior to placebo in relieving both cyclical and non-cyclical breast pain. Another study showed no difference in efficacy between oral and topical diclofenac in treating breast pain. Danazol was the only licensed drug in the UK for treating mastalgia. However, it's no longer available and it's been pulled out of the market since December 2019. But I believe it's available in the US, Europe, and widely elsewhere in the world. It is quite effective in up to 80% improvement published in randomized controlled trials. It comes in 100 to 400 milligram daily doses for 3 to 6 months. It causes early relief of symptoms from 4 weeks onwards. However, it's associated with higher rates of relapse on drug cessation, and it can cause unpleasant androgenic side effects. Tamoxifen, on the other hand, is not licensed in the UK or the US, but some use it, and it can improve cyclical breast pain in up to 71%. It can be given either as the standard 20 milligram daily dose or the baby tamoxifen dose, 10 milligrams daily. We know the side effects of tamoxifen, such as menopausal symptoms, thromboembolic disease, and a small risk of endometrial cancer. Topical tamoxifen was found to be more effective compared to placebo, and topical was found to be more effective than oral tamoxifen in reducing cyclical breast pain and with lesser side effects. There have been multiple other alternative therapies described with low-level evidence, such as vitamin E, evening primrose oil. However, in the UK, the evening primrose oil, although a lot of women report good response to it, it's not licensed as there's concern about it being harmful. So it's not a recommended treatment by our National Health Services. For those who live in the UK, the Association of Breast Surgeons looked at alternative ways of managing women with breast pain, and there has been a wide adoption of breast pain clinics across the country with different pathways, and the Aspire project is designed to evaluate these different pathways. So this study is part of the IBRANET studies, and they have a famous slogan of no innovation without evaluation. The primary point for the study is to look at the safety of breast pain clinics at 12 months and the number of breast cancer patients diagnosed within the 12 months after patients being seen and discharged from these clinics. Their secondary outcomes include patient satisfaction and costs involved. These are just an example of the different pathways that have been introduced. So alongside and separate from the breast cancer clinics, these are dedicated breast pain clinics introduced by different units, ranging from community-based breast pain clinic with no imaging, or tertiary center breast pain clinics with or without mammogram provided for women over the age of 40. The alternative options are telephone breast pain clinics with or without mammogram in women over 40. There's pathway for GP-managed breast pain clinics where GPs have access to secondary care if needed. Self-managed pathway where patients receive information sent out, and these include advice and guidance on breast pain and how to manage it, with the ability of these women to be able to request an appointment if they have ongoing symptoms after 3 months. And finally, imaging-only pathway where there's no clinical encounter whatsoever, and women over the age of 40 get an appointment for a mammogram. There have been multiple publications from the UK on the different breast pain pathways and showing really good outcomes so far. So we're hoping to wait for the Aspire study to show us the comparison between these different pathways and show us how effective are they in helping women manage their breast pain safely. Thank you, Yazan.
That's a great talk, Hiba. And we have a little addition just for a couple of minutes. Siobhan O'Donovan, she does lots of bra fitting, and Siobhan is in Ireland, and she's going to talk for a couple of minutes about bra fitting, because I think that's one of the most common causes for breast pain. Siobhan, couple of minutes. Any thoughts about that? You're on mute, Siobhan.
Yeah, thank you, Yazan, and that was a great talk, Hiba. Thank you so much for that. I suppose, like, I'm a physio, and I became aware of the fact that a lot of my patients were suffering with back and neck pain, and that they were coming in really poorly fitting bras. So I would be working with them on posture and on alignment and talking to them about that function. And then I would see them stand up maybe from the treatment couch and literally be pulled forward by gravity. And that's not necessarily only larger breasted women, which is what very often women think is the case. So I looked into it. I was sending my patients for professional bra fitting, and I felt that what they were coming back in was very often not any better. So I actually decided to go and do it myself. So I've created a physio service which combines internal support through posture and alignment and the external support of bra fitting. But in doing that, what I learned, and I now train other therapists to do it, it's a huge area. Breast weight management is a massive area that is very, very poorly served, very poorly recognized. Loads of literature telling us that women have more low back and neck pain, back pain all through the spine than men, but nowhere in that research do they mention breasts at all. So it's like it's this hidden in plain sight issue. And certainly breast pain is something that can be secondary to poor breast weight management. So what we've found since we've started to educate women, and this is really important, it's not just about being told what a bra size is, it's about learning how to fit yourself, because there are going to be lifestyle changes There are going to be times over the menstrual cycle when the breast volume increases, certainly over pregnancy, which is when most people notice it, but with menopause. So we have all of these changes that we need to be educated in being able to manage those changes, whether that's just adjusting your bra straps or whether that's going for a different size. But the point here is it's about learning the optimal fit for yourself, for your body, as opposed to relying on somebody telling you. And I think that internal side is also really, really important, because there's lots of little things that people can do just with very, very minor postural cues to get the muscles in their back, which are the muscles that do all the work, supporting their breast weight. Because we all know the pecs don't do anything, but women all think it's their pecs.
That's great. Thank you, Siobhan. So what you'll see is that if you look at people coming from different parts of the world, they all have different mixtures for breast pain. You go to Europe, they give you progesterone for rubbing it on the breast. You go to the Middle East or the Far East, they have a black seed oil. If you go to the UK, you talk about evening primrose oil. And that's mainly telling us we have no clue what we're doing. It's just the evidence behind all those things is quite low. And most of the time it does work because of that time. You're giving them for 3 months or 6 months, and that pain would have stopped anyway on its own without doing anything. Hiba, any comments on that?
So Yazan, I think the key thing for these women is to listen to them.
Yeah.
And not rush them in the clinic. And the problem is they get seen in the one-stop breast cancer clinic. They come with anxiety, they've got cancer, they come to the wrong setting, and hence the new move in the UK to move away from bringing these women to the breast cancer clinic is a huge improvement. But also these women need to be heard, they need to be examined. And as part of my normal practice, even in a busy clinic, I ask them to put on their bra. They tell me it's comfortable, but most of the time, as Siobhan said, it's just sagging down. It's not supporting anything. It's just there's a, they're just not wearing the right bra, and each brand has a different size and they're not the same. So if a woman was measured as a 38 double D from one brand, it doesn't mean she's going to wear the same cup size from another brand. So they have to understand that it has to be measured in a different way, and hence these points where I've shown on the diagram what areas on the bra to look out for and how they should sit comfortably on the chest wall and the breast are really key. So I think the first thing is to acknowledge that breast pain is not a symptom of breast cancer and avoid bringing these patients to the breast cancer clinic. Second thing is to listen to these women and examine them. Most of my patients do not come back, in all fairness. And I don't give them any medications. I just say use ibuprofen gel to help with the pain if it's severe. So I've never prescribed any of the medications I've discussed with you today from my practice. I'm sure there will be few number of patients with severe breast pain that persists despite doing all these measures that will need looking into prescribing them medications. I've not looked at giving them topical tamoxifen myself. It's not available. There's only vaginal topical tamoxifen in the UK. But I just think that their assessment and reassurance is key in the majority. And then there's a few that you probably need to work with them on how to make sure they're wearing a properly fitted bra first, and then look at other lifestyle measures they can adapt to.
And I agree with that. And most of the ladies, when they come to clinic, when they take their bra off, you can see the bra lines. Most of them are wearing the wrong size bra. I think there has been lots of discussions about imaging versus no imaging, and we'll come to that. And that's good that Nasus is here, because I feel that we should image them. Some people feel that we should not image them, and there's lots of argument about that. I think if they made the effort and came to clinic, it's an opportunistic screen, but some people say we should not be doing opportunistic screens. I don't know why. Karen, you have your hand up.
So I want to say what a brilliant talk. And I love the fact that there's more people out there checking how a bra fits, because it is a really quick fix. I also kind of caution my patients that throughout the day, the girls start to migrate out to the side. So sometimes medializing the breast, because the bra is going to move when we're moving. So I just think it's amazing. And I wanted to say thank you for a wonderful discussion.
Now, Hiba, you've seen from your data, incidence is only less than 1 in 100 of breast cancer. Reassurance is the main thing. I have no issues with that. In the worst series talking about 1 to 2% incidence of breast cancer. So why are we denying those ladies a mammogram that can pick 4 in 1,000 breast cancer, but we're still doing the same mammogram for asymptomatic ladies that have 6 in 1,000 or 4 in 1,000 incidence of breast cancer? Why?
So I think, so we know that breast pain is not a symptom of breast cancer.
Yes.
However, our screening starts from the age of 50, whereas in the US and Europe, I think it starts from the age of 40.
Yeah.
So what I tell my patients that your examination is completely normal. This is not concerning. We could do, and I do offer them an opportunistic mammogram if they're older than 40, just for that small percentage, because we're seeing more and more young women with breast cancer. So I don't think there's any harm in that, but I think what's really important to highlight, it's not being done for the breast pain, it's being done because you're here. We can do it as an opportunistic scan. We're not going to do it again if you come back again. Does that make sense? So it's not.
It does make sense, and I agree with that. I'll say it's an opportunistic screen.
Exactly.
It's not an investigation for nostalgia. You're in the clinic. And Asos, any thoughts about that from radiology point of view? I know lots of radiologists will say we don't need to screen them. Some radiologists will say yes, we need to screen them. It depends also where you are. In the private sector, of course, they'll say we need to screen them. In the NHS, we want to decrease the workload. They'll say no, we don't need to screen them. Nasos, any thoughts about that? You're on mute, Nasos.
Sorry about that. Great talk, Hiba. Thank you, Yasan. Yeah, in the private sector, of course, you have to reassure the patients in a way and the referral doctor, so you have to do something. But in general, in public hospitals, and we say what is right to do. It's no imaging, of course. There's no pain. Is no symptom from breast cancer. I think the referral doctor should reassure the patient that it's fine. Then, of course, a lot of patients are combining the pain symptom with a lump or diffuse other symptoms. So then you have to do the mammogram for reassurance and to avoid missing cancer. So yeah, please, Yasan, wanted to say something.
No, he's gone.
So then the point that Hiba said that if you have in places where screening starts at 50 or more, or they don't have a regulated screening program, then you have to do mammogram so you don't miss. It's a fine opportunity. The patient comes to the doctor for something, so for not missing the opportunity to do a screening and mammogram, then it's nice to do a opportunistic screening for those reasons. So it's difficult to say, but in plain terms, if you want to be right, then in Sweden, when we have screening program 40 to 74 every 18 months, then no imaging is advised for pain. Only pain if it's the only symptom, I have only one question, if I may, to Hiba about. I don't think I heard anything about HRT or oral contraceptives control for pain management. Is there any thoughts from your clinical point of view about that?
Hiba? Any thoughts about contraception and HRT? I always ask patients when they come if there's been recent change in their HRT or recent change in their contraceptive pill, because you would expect more hormonal type of changes in the breast that will cause the breast pain. And sometimes that gives them more reassurance. Sometimes they go back to their gynecologist or their GP and revise that and review that. Any thoughts, Hiba, from your side?
So from my perspective, so it's one of the non-cyclical causes of breast pain. I do ask the question if they're on contraceptives or HRT. Most women who are on it, they've started it before the pain started. So you find a link between them and their presentation. It is a balance, between benefit versus risk, but they just need to be aware of it. If women really need to stay on HRT, then it's just they need to acknowledge that they will continue to have the breast pain. It might subside with time. And then I talk about all the other measures like, bra fitting, caffeine and alcohol, etc. But it is a balance for them to consider either stopping it or continuing with it, knowing that it might be the cause, or it's likely to be the cause of their breast pain if it started after they take it.
There's lots of questions on the Q&A section, mainly talking about bromocriptine, people talking about other things like onagra seed, vitamin E, vitamin D. Many of those things work. We cannot address each of those, but I think many places we give about check your vitamin D, give some vitamin D and vitamin E supplements, and they talk about other things. It's difficult to know which works and which does not work. There's lots of questions about bromocriptine, about other pain medication. I've never prescribed those for pain. Most of the time, with the reassurance and simple measures, the patients are relatively happy. If the patient is in more pain, I sometimes send them to a pain specialist. Sometimes acupuncture, lifestyle measures, exercise will make a difference. And we're going to talk about lifestyle measures in October. In one of the webinars, so we're getting the people to talk about exercise, BMI, and talking about the survivorship, about side effects from the medication and treatment that we have. Last two comments before we go to the next talk. We'll start with Siobhan.
Yeah, thanks, Yaz. And just one other thing from a biomechanical perspective that can create some breast pain is asymmetry. And most women are, well, practically everybody is asymmetrical. It would be unusual, more unusual not to be. And again, we have some very simple ways to, depending on obviously the level of asymmetry, but if it's mild, then a very simple adjustment of the bra strap where one is different to the other drives me insane when I see lingerie models and all the bra straps are always the same place. It shouldn't be, because we're not the same. So there are some very simple solutions like that. But I think to reinforce Hiba's point about the reassurance, I think that whole concept of listening and giving women a safe space, that's very, very important. But then also to be able to give them some level of understanding of how their breasts behave, which might then give them some understanding of that pain. I think that's really important.
And before we go to Karen, there's comments about breast cysts and pain if the cyst is painful aspirated. They're talking about fibroadenomas and pain. It's very rare for a fibroadenoma to be the cause of pain. I've excised only once or twice fibroadenomas that were painful, and I was proven wrong in those occasions, but the majority are not painful. I excise it only if the pain is very localized. It's just, you just feel the fibroadenoma, they jump from the fibroadenoma. It's not going to sort out the pain if the pain is in the area, not in the lump. And the majority of the pain will be in the area, not the lump. Now, there's lots of questions. I'm sure that Hiba will go through the Q&A section. I think this is the busiest Q&A in any webinar today. And last final comment from Karen before she goes for her talk. Karen.
Oh, no. So just a quickie, I use this as an opportunity for all women to get a risk assessment. And when we look at a high-risk patient that comes in for something else, I see that as a golden opportunity to do evaluation for high-risk screening if they're in that age bracket, or for doing genetic testing. So I risk evaluate everyone who walks in the door.
Perfect. And after this, many thanks, Siobhan, for joining us on such short notice for this. And we'll leave you to continue with the webinar in peace. Now, remember, Karen, it's your talk now. It's about nipple discharge. And I need to remind you that NASO's PhD is in nipple discharge. So don't be that nervous out before your talk, okay? Thank you.
Yeah, thanks for setting me up. All right. So it's a pleasure and an honor to be here to, be among these esteemed colleagues of mine. My discussion today is going to be nipple discharge, types, causes, and clinical approach. I have no disclosures relevant to this discussion. So the first, of course, is going to be the overall anatomy. When we look at the breast tissue, there's 12 to 15 ducts. The lobules where the milk is made, the ducts I refer to as the pipes, so patients understand what I'm talking about. They're the conduits to the nipple for delivery of the milk. It accounts for about 2 to 5% of medical visits in the clinics, and 50 to 80% of women during the reproductive years will have some sort of nipple discharge. So nipple discharge is described as fluid from the breast. It can be either spontaneous or induced. It can be found in a pre or postmenopausal woman, and it is the third most common complaint in women after breast pain and breast masses. Yazan, I pulled this from your slide that you were saying it was about 10%, 4 to 20% associated with DCIS or invasive cancers, and the British Journal of Radiology actually had it all the way up to 33%. So when we look at it, we want to break it down because we want to find out how to differentiate what's physiologic and benign discharge, that we can just do a lot of reassurance and education for our patients, and how do we decide what's more pathologic and warrants further workup. So common in pregnancy, lactation, newborns, they call it witch's milk. Often physiologic discharge is going to be bilateral and from multi-ducts. It's usually caused by palpation. And when we look at pathologic discharge, it's usually spontaneous, unilateral, a single duct, bloody or clear. So the red flags when we look at patients who come in and they're complaining of blood-stained clothes, a persistent discharge, a palpable lump, nipple changes. So we look at clinical exam, age older than 40, and in men. In men, it's usually considered pathologic all the time. First, we want to evaluate on the clinical exam the types of discharge. So we refer to the colors. When we look at the color, serous or yellow, milky, mucinous, clear, watery, sanguineous, bloody, serosanguinous, pink and bloody, purulent, or multicolored. So those are the different types, and you can see on the diagram that they're associated with either breastfeeding, galactorrhea, hypothyroidism, polyctonomas. Usually you can have ductal ectasia, intraductal papilloma, and we're going to get into that a little bit more. Most common cause of benign nipple discharge is going to be an intraductal papilloma, commonly associated with a bloody discharge, sometimes clear. Also benign causes are going to be ductal ectasia, usually presenting as a bilateral discharge, which is green, yellow, or brown, multicolored. Fibrocystic as well can be multicolored. And infection is going to be more associated with a viscous, darker discharge, sometimes that smells, usually associated with mastitis and abscess. When we look at non-breast causes, galactorrhea usually is a milky discharge in a non-lactating woman. If you look at the diagram, it's usually secondary to a mass. You can also have that galactorrhea caused by medication, hormonal imbalance, hypothyroidism, or pituitary disorders. So a lot to think about. As I mentioned earlier, the Journal of British Radiology has stated that it was about 5 to 33% associated with an intraductal carcinoma or DCIS. Things that would make you think more malignancy would be bloody discharge, a single duct, age over the age of 40, palpable mass, and in a male. When we look at history and physical, we want to look at the ductal involvement. Is it coming from one breast or from both breasts? Is it a single duct or several ducts? Is this happening with stimulation or is this spontaneous? And a lot of times patients aren't going to know the difference. They might present to you with saying that their bra is stained or their nightgown is stained. So these are all things that you want to take note of. The color of the discharge, how long has it been going on? Is it intermittent or is it constant? Is there a palpable mass? Does the patient experience any pain? Have they started any new medications, any skin changes, or enlarged lymph nodes? When we look at the clinical evaluation, thyroid is the hormonal regulator for the body. Things that would be concerning would be cold intolerance, fatigue, constipation, or weight gain. So that might put you in that direction to work up hypothyroidism. If we're looking at a pituitary gland or a hypothalamus disorder, we're going to start looking at menstrual cycle, amenorrhea, where they have no menses, infertility issues, change in vision or headaches. When we also look at, causes, we have to evaluate kidney function or liver disorders. A lot of these patients would know these symptoms or come full disclosure and have that on their medical history when they present. But if they don't, it's important to remember that this could be a cause. Things like ascites and jaundice. Clinical evaluation of medications is really important, and 90% of the time in my practice, most patients don't even know what they're on. So it's important to ask them, and if not, to have them review their medications because they sometimes don't remember everything they're taking. Things to be suspicious about are opioids, contraceptives, GI medications, cimetidine, ranitidine, metoprolol. Ranitidine has been taken off the market in the US because it is felt to be a carcinogen, so no longer really an issue here, but in other countries, it's something to look for. Antidepressants and phenothiazides are things that also can cause a problem with nipple discharge. Antihypertensives such as atenolol, labetalol, methyl-dopa, reserpine, verapamil. Also, looking at that can be a quick fix to figuring out what the causation is. When we look at how do we work this up, what are we going to look for? Looking at prolactin levels, thyroid stimulating hormones, liver function tests. There is a nod to cytology, which I'm going to talk about later, but cytology has really fallen out of favor. Basically, there's a high false negative rate. When we look at imaging, there's ultrasound, there's mammogram, there's ductogram or galactography, MRI, and if there's a suspected pituitary tumor, MRI of the head. So I will get to MRI testing. Imaging testing. When we look at ultrasound, it's got a very high sensitivity, anywhere from 63 to 100%. On ultrasound, you can see ductal ectasia being defined as greater than 3 millimeters. The dilated ducts, you'll get sometimes an anechoic fluid or a hypoechoic debris that's found in these ducts. It's actually medical student friendly. The resident or the students can look at it and you can see these dilated ducts. And it's very reassuring. I tend to pull up the images in the clinic for the patients to see because, like I said, most of the time these are going to be benign findings, and it's very reassuring to see something that can support a benign finding. In certain cases, you'll find an intraductal papilloma. This will be seen as a hypoechoic nodule with a central vascular pedicle. If you have a Doppler ultrasound or if your imager has the Doppler image on the screen, you can see that as a stalk, and that's very helpful. When we look at mammogram, it's actually got a very low sensitivity for nipple discharge. What we look at mammogram is to exclude microcalcifications, branching, linear, segmental distribution, pleomorphic calcifications. When we look at mammogram, we're also looking to find any masses. Now, they may or may not be relevant to the nipple discharge. Sometimes we find something that we don't anticipate. A lot of times we're looking for asymmetry or distortion. When we look at a mammogram, we can see sometimes ductal ectasia, which is demonstrated by increased density in the retroareolar mammogram. So I guess it's sad to say that galactography or ductography is something that when I was coming up through my fellowship was in abundant use. It's about 15 minutes. Basically, you are going to cannulate the duct that is performing the discharge. You're going to use an ionized contrast, about 0.5 to 1 milliliter into the duct that is discharging. You'll do a standard mammogram, and at the end of the case, you're going to aspirate out the contrast and use manual pressure to get rid of it. The trouble with galactography is that it is very painful. In many cases, it's only present if you're able to cannulate the duct that is actively producing the discharge. So if patients have intermittent discharge, you're not going to be successful in being able to cannulate something if you don't know which duct is producing. The possibility is also there for a duct rupture. So when you look at this, there is a risk, as well as in 15% of patients, this type of imaging is going to fail. So when we look at ductoscopy, also very prevalent during my training, Joseph Crow at the Cleveland Clinic, actually a relative of Russell Crowe, was a very big proponent of ductoscopy using a microendoscope of about 0.9 millimeters. You get direct visualization. It can be positive or negative. A negative is a normal duct. There's nothing there. And the negative predictive value is very high, 98 to 100%. However, in the US, it's very unpopular and very limited because in the US, we don't have access to the biopsy devices. So it kind of came about during my fellowship and went away after I finished my fellowship in terms of what I saw for uptake in the US. And I believe in other European countries, there is an issue with the biopsy devices. When we look at, what is available for, imaging and workup, in the US, it was thought for a long time that surgery would be the standard of care. And recently, the MRI has really surpassed evaluation. I personally believe that doing an MRI prior to a surgical intervention is helpful for me to get a lay of the land and have an assessment of the area of involvement. It's got a 90 to 99% sensitivity, which is wonderful. It shows non-mass-like enhancement, segmental or linear, often associated with cancer. So when you look at this, you're able to have a better scope of practice for what you're going to need to resect if it's how extensive it is. Dilated ducts are able to be seen on hyperintensity on the T2 weighted images. And the possibility for intraductal papilloma will show as a well-circumscribed mass, which is homogeneous. I like MRI for the fact that I'm able to look at both breasts. It's physiologic and morphologic evaluation. You can evaluate multifocal or multicentric. You can have an occult lesion that is picked up. It could be more of an incidentaloma, but at least you're finding it. And when we look at it, you can evaluate multiple duct workup or uncertain or intermittent. So once again, some of the other previous modalities for workup and diagnostic imaging are only going to be useful if you're actually currently having the discharge and able to identify the ducts discharging. The limitations of MRI, it's very low specificity. It has a high cost. There are patients who will not be able to tolerate IV contrast and patient discomfort, such as individuals who have anxiety, claustrophobia, unable to lie prone. It takes about 45 minutes. There's different variations of looking at direct and indirect evaluation of doing dye through the nipple during the time of the MRI, but that's fallen out of favor. In the US, we predominantly use just contrast-enhanced MRI. And while this came from the British Journal of Radiology, American research shows 60% of cases, radiologists will recommend MRI. I would say that in clinic, I've seen that more like 85 to 95% based on where you practice. So when we look at treatment, as we mentioned earlier, the most important thing is to remember that the majority of these are going to be benign. And once you've gone through what we discussed with all of the evaluation of the history and physical, is it going to be medication induced? Is there the squeezing or the pressing? These are things that you want to look into. If it's antibiotics for an infection, that's what we're going to recommend. A lot of times it's education. You'll be surprised with how many patients have physiologic discharge, and once they notice it, they actually start to squeeze to express it, to keep checking on it, which is actually only exacerbating the situation. So educating patients to stop expressing or squeezing is not only educational, but therapeutic. So when we look at the next steps, some patients are really traumatized. They'll say that, they're going out and it's staining their shirt, or they're finding it on their clothes. And so they want the duct to be removed. So if we are looking at a papilloma, they can do that. Or if they're having persistence, people will recommend a microductectomy, which is localizing that. When we look at galactorrhea, which is the production of milk, it's important to remember that treatment can be as simple as identifying the culprit: sedatives, antidepressants, antipsychotics, blood pressure meds, as we mentioned, opioid use, herbal supplements such as fennel, anise, or fenugreek seed, which was new to me. I never heard of that before. Birth control, low testosterone in males, or hypogonadism, is an important evaluation. When we look at the pituitary tumors, the first line of treatment is going to be medication. So dopamine agonists are what we recommend, carbagolazine and bromocriptine, but bromocriptine has been falling out of favor because it has a lot more side effects. We look at underactive thyroid, and that's a treatable disorder. So a lot of these things can be easily treated and manipulated by the identification. As I mentioned earlier, stimulation, it's important. It might be a little embarrassing for the provider to ask, but it shouldn't be, about sexual relations. And I had a patient who was a professional dancer, and that was part of her act. And I diagnosed it and treated her, and she never had an issue with it again. This was interesting to me in the research for this presentation. Nerve damage to the chest wall, spinal cord injuries, and stress can also cause a galactorrhea. So looking for stress reduction techniques, as well as reducing stimulation. When we look at the surgery and the aspects for how to treat it, there's two types. The surgery is either broken down into a major duct excision or a selective microductectomy. I personally perform it using a lacrimal probe, which is a 00. I cannulate a duct that is discharging, and then I will tattoo it with a little methylene blue. I use a pediatric catheter and hyperpigment the track so I can identify it for when I make a periareal incision. I get in, I can see the probe as well as the tattooing in case while you're manipulating the duct that comes out. When I spoke to my colleague in Brazil, he uses an insulin syringe. He cuts the tip of it off, so it's a blunt catheter, and then he uses that to inject the methylene blue to tattoo. A colleague that I met through iBreastbook, who is in Dubai, Zidane, it basically says that he only uses a lacrimal probe, and he fixes it with a steri-strip so that it doesn't work its way out when you're manipulating surgically to identify the duct, and that's the culprit. So I think that's one of the benefits that I love about iBreastbook is hearing different ways that people approach similar problems throughout the world. Always great to learn different tips and tricks. When we look at possible complications, inability to breastfeed, loss of nipple sensation, and retroareolar necrosis, that's usually associated more so with the larger ductal excisions. So when I'm putting up the anatomy slide again, when we're looking at this, the single duct, obviously minimal dissection can preserve a lot more benefit for women who have not had their children and an attempt to preserve breastfeeding. When we're looking at a total duct or a major duct excision, Hatfield procedure, you want to be much more careful. Ricardo Pardo, who's not here, he's golfing today. I sold him out and I told you the truth. He's golfing instead of being here. He usually uses a 90-degree quadrant. So from 12 o'clock to 3 o'clock, or looking at the culprit where he's going to go. If he's doing a microductectomy and if he's doing a major duct excision, he's going to take out more. But it's important to try to reapproximate the tissue at the end of the procedure. I'm not going to go into it because Yazan has an absolutely beautiful video that he's posted online. And if you put in major duct excision, there's a lot of different imaging of videos. I like his because I tend to use a mosquito myself. I like the fact that it curves around. Some people use an incision and then use a straight scissor. I think that the mosquito, a fine mosquito, is a little less traumatic and does a little less dissection in the normal tissue around the nipple areolar complex. So I have a large and busy flow diagram here, but I think it's really comprehensive. And this I stole, full disclosure, from the British Journal of Radiology. So I'm glad that probably one of the authors is sitting here watching me present breast discharge. Thanks, Yazan. But really, it's important to differentiate between suspicious pathologic discharge and physiologic discharge. A lot of the bilateral, intermittent, multi-ducts, greenish yellow, multicolored are going to be more of a benign finding, starting off with ultrasound and mammography. For women less than 30, we recommend just starting off with the ultrasound to evaluate. In women who are 30 or older, they're recommending mammo and ultrasound. If positive, you're going to do an imagery-guided biopsy. If negative, you can continue with follow-up or routine. I always do risk assessment, and if I find that someone's negative and they have a high risk assessment, I might then actually reflex to MRI. So I think it's a discussion. I do a discussion with every patient. I discuss pros and cons of imaging. When we get negative testing for anything that's abnormal, if a patient is high risk, I would sometimes consider doing MRI depending on their age bracket. When we look at pathologic evaluation, the spontaneous unilateral from a single pleural or bloody or serous discharge, once again, starting off with ultrasound and mammography. Here, breast MRI is incorporated in the algorithm. If it's positive, they're recommending surgery. I would say biopsy would go in there beforehand. A second look ultrasound, which has, I just found out, been replaced with the term a targeted ultrasound, because for many years, if you had something on MRI, we would do a second look ultrasound to find what was suspicious on MRI. My radiologist now corrected me to say that we are now doing an MRI targeted ultrasound. And if something is identified on the ultrasound after the MRI, then we biopsy it that way. If available and able to be biopsied on the MRI, that might be a consideration to get the location. And that's a discussion as well with looking at how extensive the area is. If it looks as though this is someone who's going to need a larger extensive surgery and a complete ductal excision, then maybe no need to go in there and do a biopsy in advance. But that is a discussion depending on the MRI positive results. So when we have an MRI that is negative with no ultrasound or mammography findings, continue reassurance, follow-up routine screening. MRI biopsy, if possible, is always a good option. And if positive, always for surgery. If negative, flow back to routine screening. I think I really powered through this presentation. It might have been like 5 minutes. Sorry, Yazan. So nipple discharge summary, I felt like this was a really nice, concise way to kind of clear up that flow chart that I just presented, looking at, the lateral, is it unilateral or bilateral? Is it multiple ducts or single duct? The color differentiation, is it spontaneous or expressed? Age, more common, benign findings in younger women. And if you're older or a male, then it is more suspicious for something pathologic. When we look at associated findings, if there's no mass or skin changes, it's more likely ductal ectasia or maybe clinical palpation, which is being stimulating a discharge. If there's a palpable mass, then you're going to work that up as a palpable mass. If there's skin changes, that's something to be suspicious. And as I mentioned, I'm a big fan of risk assessment for every patient. And remember to check axillary nodes for exams. Common causes for benign, galactorrhea, hyperprolactemia, medications, very common. Like I said, remember that most of your patients may or may not be fully aware of all the medications they're on. So I always ask them, have you started anything new? And that's where you can get into asking about herbal supplements as well. Fibrocystic change and ductal ectasia, these are really wonderful things that if we can identify in clinic, can provide education and support and usually a quick fix. When we look at it, it's really important to remember that when we have something like an intraductal papilloma, which is the most common cause of bloody nipple discharge, approximately 57%, we're looking at making sure that we do a proper workup to rule out any atypia on the biopsy. And if we have atypia in the US, the position statement is intraductal papilloma on core biopsy. If there is no atypia or malignancy identified, it's reassurance and follow-up imaging. If there is atypia in the US, we do recommend surgical excision for further evaluation. Even if I have a negative, I also will pair that with looking at risk assessment. And when we talk about surgical excision of involved ducts to evaluate, we have several techniques to identify how much, which is where I heavily rely on MRI, maybe more so than some of my colleagues, just because if I'm taking someone to the OR, I want to have a broader scope of evaluation prior to get into surgery to prevent any reason for going back to the OR. When we look at the differentiation between the two sides, physiologic, which is benign, and pathologic, suspicious, I think it's really going to go back to really a dedicated history and physical exam, medication lists, labs, and staging of your imaging. So thank you all for showing up. Many thanks to Yazan and his team. I say thank you for me as a provider and this international group of my colleagues, since it has helped me tremendously to have an international resource, and for my patients, when I give disclosure that I learned something on iBreast book that they benefited from. So I thank you all, and I'm open to questions.
That's great talk, Karen, and it's really very, very big topic to cover. And people don't remember that nipple discharge is a symptom. It's not a problem. Most of the time there is no problem behind it. And I feel that many ladies are having surgery that they really don't need. The majority is benign or physiological. Now, because you mentioned this is international format, that I tried to get Mirvat Saleh. Mirvat, you're online now? I think you're mute, and you're also, your camera is not on. So Mirvat is one of the senior surgeons from Kuwait. So she's joining us also on the panel. I tried to get Victor Acosta also, but he's on the beach. So he does not want to join the beach. I told him Alberto Rancati joined from the beach in the past, but he's not listening to me. How are you, Mirvat? Great to see you. I think you're still on mute, Mirvat. And Nasos.
Yeah.
There's lots of variation on how people image. In the UK, we don't tend to use MRI scan. We tend to use mammogram and ultrasound scan. But I know MRI scan is very sensitive, and many people use it in Europe. So any thoughts about imaging for nipple discharge?
Great talk, Karen. Thank you for that.
That's scary.
You covered everything actually, but as you said, MRI has the highest PPV value. It's a great method to use. I mean, galactography is old news. We don't use it in at least in Stockholm, Karolinska. So beside that, there are some specific MRI protocols now for nipple discharge with high T2 value, and I think we should use, especially if you think that's a suspicious nipple discharge, not for every discharge, but if you have suspicion on pathology behind this, then you should use nipple MRI, I think, breast MRI. Then I have a comment on the therapy. I think we should add VAE, vacuum-assisted excision, not only for excising papillomas with or without atypia, even for symptomatic reasons. I think I was in a workshop with Tom Stavros from University of Colorado. He was really using VAE for symptomatic patients without any pathology behind it. It was really great effect. Then I saw some questions about contrast enhanced mammography that I don't think should be used in these occasions. It's a great method, but not for showing pathology for nipple discharge.
CEM will not work for nipple discharge. It works for many other things, but I think for nipple discharges will not work that well. Now, the other important thing is you mentioned that the ductoscopy. I've seen it when I was training in the Marsden. I don't think that many people are doing ductoscopy. Ductography also, I don't think that many people are doing ductography.
No, it's really fallen out of favor, and it's more of a historical evaluation. So, but I figured I'd present it because, like I said, when you're on an international platform from people all over the world, different countries have access to different tools. And so that's why I think it's important to go through what's available.
And we will talk, there will be a B3 webinar again, maybe towards the end of the year, because there's different indications, which B3s to take out surgically, which B3s to monitor, which B3s to biopsy. The reason you take a papilloma out if there is atypia, because you can miss DCIS if you hook it. But
what I often say is, if it's a stock and you're coming through with a biopsy, are you taking everything? No, you're taking a sample. And so are you leaving something that's pathologic at the tip or at the base? So when you're looking at it, that's when I explain to patients that if there's atypia, we don't get a full assessment.
but also when there's atypia, the pathologist will need to see the whole papilloma as
Yes.
a whole to say if there's this papillary size or not. No, not. If they
Yeah.
see
Pathologists love more, always love more.
Mervat, any comments about
Yes.
discharge? Do you see anything? Is it different in the Middle East, the presentation and the management of nipple discharge? Because
Thank you very much, Yazan. Thank you for your work. Beautiful lecture. We're following the same. atypia has to be excised, investigation the same. I just have a question for you. You didn't mention anything about contrast enhanced mammography. Do you think that will help and replace MRI of the breast?
so we just mentioned that when we were trying to because I think what Nasos is saying, for in this occasion, CEM might not be as helpful as MRI scan. Am I correct in my assessment, Nasos?
Yeah, of course. Yeah, that's true. Because you want to see, papillomas. You want to see small things that they cannot have so much uptake to be seen in contrast enhanced mammography.
So
The resolution is better on the MRI for the smaller papillomatosis and things like that.
Okay. Do you do MRI for all intraductal papilloma or selected cases?
I think that a majority of the time, if you have something that is seen on mammogram or seen on ultrasound, you can do mammogram biopsy or a targeted ultrasound guided biopsy. Obviously, we prefer an ultrasound guided biopsy. It's just more comfortable for the patient. And a lot of these are going to be sometimes very superficial. So it depends on the location. But what I would say is the MRI is going to be the default. If you have a negative mammogram and a negative ultrasound and your patient is still symptomatic and you want to make sure there's nothing else going on.
That's it. Exactly. That's what we do. We go only for MRI when the ultrasound doesn't give us a clue of the diagnosis and we cannot reach that one. We'll go for,
We rarely use MRI scans. Do you use MRI scans, Hiba?
No, unfortunately. I've used it once for a young patient who was bleeding through the nipple, actively bleeding, actually, without history of trauma.
I usually try to use it to avoid operating on a young lady because the surgery is not a great operation. The surgery, loss of nipple sensation for a young lady also might lose the ability to breastfeed. So the consequences of this small operation is big for a 20, woman in her 20s or 30s. So we try to do MRI scan only when I'm trying to avoid operating on patients. Akram, you have your hand up. Yeah. So I think if there's any other comments before we go to the last talk, because we have only 25 minutes left. Now, anything else about nipple discharge? It's a very big subject. It's very difficult to cover, but anything that will vary in different parts of the world. Any comments from anyone? Yeah, Hiba, your hand, is that a legacy hand or is that new?
It's new. I just wanted to thank Karen. What a fantastic talk.
Oh my God.
I
was so scared.
There's so many medications I wasn't aware that can cause nipple discharge, and probably taking
Well, and that's why I thought it was important. I mean, it wasn't a lot of citing studies, but this is one of the best things about iBreast's book is having access to all those slides, because there are so many medications and that can deter a patient from wanting to go to surgery because they're so scared. And if we can just manipulate medications, it's much more cost effective for the society as well as for the patient. And so that's why I was like trying to shove everything in there and speed talk.
Well done. It was really great.
Very nice talk, Karen. And we told Nasos not to ask difficult questions, so we're all fine for now. There's lots of questions on the Q&A section. So if you, Karen and Hiba, if you can have a look at that. I think there's only a few left of those questions, but if you can look at that, that will be great. Oh, there's 38 questions open still. We'll play the last talk. It's only 13 minutes, and we'll do a bit of discussion after the last talk. So Jenny Hughes, unfortunately, could not be with us today. She's away. So she sent me a recorded talk. So I'm going to play that. Can you see my screen? Can you all see the screen? Can you hear?
Hi, hello everybody. My name's Jenny Hughes. I'm a consultant dermatologist in South Wales. I'm here today to talk to you about benign skin conditions of the breast, and I'm sorry I can't be here in person, and many thanks to Professor Yaz Masannat for asking me to speak on this topic. So I've got no disclosures relevant to this talk. And what I'm going to cover, obviously the common skin conditions that you're all aware about, especially eczema, which I think you see a lot of, psoriasis, benign lesions, but also some more uncommon skin conditions that affect the breast that may be of interest to you. So I'll first start with a case, and this is a 53-year-old lady who was referred with a lesion on her left areola, and you can see she was fit and well, and she'd had it for coming up to a year, but she'd noticed discoloration, and when she noticed bruise-like areas, this alarmed her and she went to see her GP. And this was the appearance around her areola. You can see a pale area with rather an erythematous edge. And here in between the breasts, you can see rather shiny skin with hemorrhagic areas, and some areas of skin almost looks like atrophy, a change known as cigarette paper thinning. And this is lichen sclerosis in an known as extragental lichen sclerosis. And it's very commonly seen on the breast or the chest, often asymptomatic. And these typical atrophic lesions, occasionally hemorrhagic. And if you ask the patients or they're examined, they'll often have a vulval or perianal involvement as well. And treatment is with steroids. This can treat the hemorrhagic areas and stop it from advancing, but you will still remain with white white atrophic areas. They will be long-term. And these are the changes seen in the vulva in lichen sclerosis. Again, you've got the hemorrhagic areas on the left, and you've got the white atrophic area and some distortion of normal vulval architecture. So the next case is a 67-year-old female with psoriasis, long-standing, and she'd been for long-term on subcutaneous methotrexate, very standard treatment. She developed an upper respiratory tract infection, possibly COVID, and started to become very unwell and developed a more widespread painful rash. This particularly affected the breast area with ulceration and gradually increased towards widespread redness and erythroderma. The patient was admitted to ITU. She was treated with biologic agent, too late, unfortunately, in this poor lady's case, but she progressed towards renal failure and multi-organ failure. Luckily, most psoriasis doesn't present in this way, but it is a reminder of how severe the condition can be. And as breast surgeons, you'll most commonly see flexural psoriasis affecting the breasts. And this rash often doesn't have the typical scale that you expect of psoriasis affecting the knees and elbows. The skin will be erythematous and shiny, and it'll often have quite a delineated edge. And the key thing is to ask the patient about lesions elsewhere or family history of psoriasis. Here's another example with symmetrical, rather kissing lesions, again in the flexural submammary area. And it's a high impact site for patients, and you will be referred these patients. And we tend to start off by treating patients with moderately potent topical steroids or calcipotriol cream, and depending on how severe their psoriasis is elsewhere or where else they have flexural disease, they may go on to need other systemic agents such as methotrexate or biologic medication for their disease. And the next case is a 43-year-old female, 2-week history of a rash. She travelled to Spain. She was on tamoxifen for previous breast cancer, and she developed an annular rash on her back, chests, and breasts. She feels okay, slight flu-like symptoms, and a bit tired and fatigued. And these are pictures taken from the internet. You can see there's an annular, scaly erythematous rash with some central clearing, quite widespread. And this condition is known as subacute lupus erythematosus, and it's a subtype of lupus commonest in middle-aged females. and is most likely to be seen on the breast and chest area. It's non-scarring. About 30% of cases are caused by drugs, most commonly calcium channel blockers or PPIs. And the patient may also have positive Rho-or-La antibodies, making them susceptible to UV light, and a positive anti-nuclear antibody. And treatment is with oral and topical steroids, hydroxychloroquine if needed, and stopping the offending drug if it's a drug-induced cause. And here are some more examples of systemic lupus erythematosus. Again, the chest and the upper breast may have exposure to ultraviolet light. And here is a case taken from the internet, again, affecting the breast. And you can see here how the systemic lupus erythematosus has gone on to cause scarring and hyperpigmentation. And this is part of a more widespread condition. We're often asked to see lesions affecting the breast. And here you can see an offending lesion. It's brown, it's recently appeared, it's become itchy, it's quite well circumscribed. But the question for us is this a benign lesion or not? And the way we can tell this is by using dermoscopy, essentially polarized light with a magnifying glass. And you can see here, it's a well circumscribed lesion with comedo-like openings and cysts. And this lesion is a seborrheic keratosis. This is an example of the dermatoscope that we'll use to look at lesions affecting any part of the skin, but including the breast. And this is how it's applied. You apply it directly to the skin and use the magnification to view the lesion. And this patient was sent with a lesion on a breast, sent up as query melanoma. Does look dark, slightly reddish. And again, dermoscopy gives us the answer that this is a benign lesion. You can see the looped vessels, that this is a hemangioma. And there you have the two lesions, the macroscopic and the dermoscopy image side by side. So that's very useful looking at lesions on the breast. Moving on to atopic eczema, I'm sure you're often referred patients who have query Paget's or query eczema. And the nipple and the areola complex is a common site for atopic eczema. It's much more usually bilateral, and secondary infection is common, so that the rash is often weeping and may have secondary infection, sort of a golden crust. Secondary infection with Staph aureus is very common. And this will respond to topical steroids, but often relapses. So more prolonged treatment may be needed and using slightly stronger steroids. And here are some examples. You can see that there's diffuse scaly erythema with weeping and crusting, affecting both the nipple and the areola. And this, however, is a condition you'll all be familiar with, Paget's disease of the breast, again, usually unilateral and rather better circumscribed. And obviously this would require an urgent biopsy. So nipple eczema or Paget's disease of the nipple, I went through differences. Obviously, atopic eczema is a very common condition affecting up to 20% of the population, and a significant proportion of those patients will have eczema affecting the breasts, especially if there's friction from exercise, running, or large breasts. Often affects both breasts. Paget's would typically be unilateral. Differences with eczema, it starts on the areola, spreads to the nipple, which is the opposite in Paget's. And Paget's, you don't expect improvement with steroid cream or other treatments for eczema. And there wouldn't be any evidence in Paget's disease of rash elsewhere, whereas patients with eczema will often have a rash of their antecubital or popliteal fossa. Another condition that's becoming more and more common and affecting the breast is hidradenitis suppurativa. And this is a painful condition causing abscesses and sinuses, and affects flexural areas, so breasts, axillae, groin, more common in the females, There's often a family history, and it's linked with smoking and being overweight and metabolic syndrome. And it also has a link with inflammatory bowel disease. And this is an early example. You can see these rather painful abscesses and comedones, and more advanced disease where there's sinus tract formation with scarring and chronic discharge, very painful, distressing condition. And management of HS is multifactorial. We need surgical help as well, but also medical measures are very important that I've listed here, including losing weight, using anti-inflammatory antibiotics, and anti-TNF biologics may be of help as well as anti-IL-17s. And coming to the end of the talk, I'd just like to mention pyoderma gangrenosum of the breast. It's a rare condition, but a really important condition to treat quickly and to gain help with. I had a similar patient to this, but she didn't want images to be shared. And this is a case I've taken from the internet. This condition causes rapidly enlarging painful ulcers, and there's usually purple undermined borders and pathogy. So it's important to avoid surgery as much as possible. Obviously, a biopsy is important, but certainly avoid any debridement. And this shows the progression in this lady, who don't think had any underlying conditions, but it's usually commonly seen with patients with underlying inflammatory bowel disease, arthritis, or hematological malignancy. So on the first week, there was just a painful area that looked like it might be infective. And by week 4, the skin had broken down for an ulcer, and you can see this rather ragged purplish edge. And then the lesion progressed, very painful ulceration, and on week 24 after treatment with oral and topical steroids, it was starting to heal, but with quite significant scarring. And this is an example of pathogy-related pyoderma gangrenosum following reconstructive surgery. So it can happen post-surgery or injuries such as dog bites, but sometimes it can just arise de novo in patients, but it's something to be aware of. Like I said, it's commonly associated with underlying inflammatory bowel disease and other conditions, but sometimes can arise de novo. Treatment needs to be timely. Steroids are your first line agent, and using other medications such as cyclosporin and biologics is also important. And that's a brief run through of some benign conditions of the breast. I hope that's been useful to you in your practice. Thank you very much.
Perfect. That's a great up to the point talk. So let's stop sharing. Perfect. Perfect. So shall we have all the panelists again? We'll have a short discussion. We have only 10 minutes left. And shall we start with Mirvat? Mirvat, any comments?
Yes, thank you very much. Beautiful lecture. I would like to comment on something very important, is that dermatologists, we need their advice, they need us. So I have few comments, or let's say I wish the speaker is with us to ask, when do they go for biopsy in the breast if they suspect that there is an underlying problem? Second question, when do they refer to the breast surgeon? And when do they take the advice of a radiologist? What do they do? Do they request sometimes ultrasound or other like mammo, MRI? Do they depend on the radiology like we do? Because it's very important for us, a biopsy and radiology. Now, on the other hand, when do us, this is for our breast surgeon, when do you refer to dermatologist? We know now a doctor is not a doctor for everything. We have to take the advice and the opinion of other specialty, because they know better in every area in the tissue. That's my comment. Thank you.
I think it's a fair comment, and it really depends where you work. I don't think that the dermatologists in the UK have access to mammograms and ultrasound scans. So anybody that has anything in the breast, they'll end up seeing us. If I see something on the nipple, I just punch it, and that gives us an answer. It's a simple procedure. Sometimes with hidradenitis, you send to them. Sometimes with psoriasis, you send to them. But really depends on where you work. Hiba, you had your hand up?
I was just going to say the same. We get referred any skin lesion on the breast to our breast clinic because we see them the quickest. The waiting time for a dermatology clinics can be months. So we are, as a specialty, the quickest to see patients within sometimes even 2 weeks. I punch, biopsy any skin lesion. If I have a diagnosis that dermatologists need to deal with, then I refer to dermatology straight away. It takes months for them to get seen.
I think our waiting time is months here. I think in Scotland was much longer than that, in all honesty. And I think for skin cancers, it's difficult even to have treatments. I think you're in a blessed place, Mirvat, that you have the option for them to see things for you quickly. So that's great to know that. Karen, you have your hand up?
Thank you.
Yeah, no, I was going to say the same thing here is that a lot of times we're the first stop because anything with breast comes to the breast clinic. And in my current location of practice, it is about a 6-month wait list to get to dermatology. So in many cases, I'm doing the punch biopsy and workup and then sending them to pathology, getting that evaluation, and then referring them to the dermatologist at the same visit, but their actual visit with the dermatologist will have the pathology results.
So it's great to know that you also struggle with dermatologists. It's not a UK only
No.
Now, sometimes some of those skin lesions cause recalls for mammograms, isn't it?
Yeah, well, we don't have dermatologists as reference doctors to us. I don't remember any referral doctor, dermatology referral doctor, but of course, Paget is maybe the most usual finding for us. We do mammography, ultrasound, of course. We often don't see anything. We proceed with MRI for confirmation of eventually pathology behind the areolar region. And at some cases, we perform also puncture, skin puncture, because it's quicker than referring to the surgeon. So otherwise, I don't know if we can add so much information from our point of view for those lesions.
I've seen 1 or 2 ladies that had something that appeared on the mammogram. They were not sure if it's from the skin or not. And the radiologist put an ECG dot or a little metal on it and then repeated the mammogram, and it just corresponds to that. Sometimes there's certain recalls because of skin lesions sometimes on the mammograms. Am I correct in saying that, Nazos?
Yeah, of course. And of course, there are rare skin metastases from people who have breast cancer that we can see in ultrasound. So yeah, of course, we have to check the skin really closely.
And I will just say one last thing because we have only a few minutes left. Pyoderma, heart sink when it happens. I had one lady that happened to her post-op and her breast fell apart. She had a mammoplasty. And it did not cross my mind until the thing healed. Unfortunately, she needed to have the re-excision of margins. So when it was half healed, I took her back theater and did the mastectomy. But when this happens, it's really a heart sink. You can do nothing. You're just watching the wounds disintegrating in front of you, and it's not the usual necrosis that you have from problem with a wound healing. You're just looking at something that says, I really have no clue what's happening there. And if there is something that is odd happening post-op or even pre-op, just get somebody else to have a look at it. Plastics will be great from that point of view. Dermatology will be great from that point of view, because it's really a hard thing. I still remember that lady. And it lasted for nearly 3 months until things started improving, and she just needed her re-excision of margins. Now we're only 3 minutes from 6. Any final comments before we close today, because we still have 460 people online, which is great. Any comments from anybody?
I was just going to say, in the US, we actually use little markers that are radio opaque. So
Yeah.
if there's something on the skin, it'll be a circle. So they're supposed to put it on there. I
Yeah.
actually train my patients to ask for it if they have like a seborrheic keratosis or something on the skin or a mole. So that marker gets on there, so it's not misconstrued as in the breast or something that is going to be missed. And triangle if there's something palpable.
And of course, deodorant can cause lots of calcification to be seen or false calcification seen on the mammograms. Little things sometimes make a big difference. So it was great to have you all. Remember, the next webinar is on sarcomas and phylloides, because now we have just published the new UK guidelines for phylloides. So we took the opportunity to get that in a webinar, and we have fantastic talks between the UK and Italy. It's in 2 weeks' time. It's on the 13th. Then we'll have, I'm planning one on survivorship issues and lifestyle measures, which will be in October time. There'll be one on B3, most likely either October or November time. And there's a couple of other webinars that are in the pipeline. So keep an eye on things. If you are not on the WhatsApp channel, I've just shared the link again. Please join the WhatsApp channel. Many of you are also on the WhatsApp groups. So first of all, thank you for the speakers and the panelists for giving up your time over the weekend to be with us. And thank you for everybody that has attended from all across the world. For people in the States and South America, have a lovely day. For people in Europe, have a lovely evening. For people in the Middle East and the Far East, have a good night. Thank you, everyone.
Thank you.
Thank you, Yazan. Thank you, everyone.
Thank you.